Joshi, Dr. Ansi Shah, Dr. Harshad Bhai, my friend, and Dr. Arun Bhattacharya. Dr. Bhattacharya, again your service will be needed today, as usual. For a formality, I would like to request Dr. Harshad Bhai to kindly introduce the speaker. He doesn't need any introduction. None of these speakers needs any introduction. And everybody is waiting for this debate only. I think so many friends of mine, they are waiting for that debate. Let us hope that we will have that debate, very hot debate. Thank you.
I think I invite Dr.
Dr.
Anil
Mihir
Bha-
Tanna, Dr. Atul Maslekar, Alpesh, Dr. Alpesh and Dr. Karthik. They may join later on. Kindly introduce formality. Harshad bhai, you can do that.
I invite Dr. Anil Jain, who is a leading cardiovascular surgeon of India, I would say. Anil bhai, please go on.
I think we start straight away. I guess.
A 77-year-old male patient has exertional angina, class 3 and 1 episode of pre-syncope. He also has obstructive pattern in PFT with COPD, which is currently well controlled on oral medications and occasional inhalers. He has normal coronaries with LMCA takeoff, 6 millimeter from a 70-year-old male without, so I can, Dr. Anil can. 70-year-old male without diabetes and hypertension with history of anterior myocardial infarction 3 years back. Presents with non-STEMI with 99% type A proximal LAD. 90% type A lesion in major OM. Echocardiography showed severe LV dysfunction, LV apical aneurysm without any clot or no significant MR, without annular dilatation. He is further evaluated for LAD, territory for viability of on SPECT and cardiac MR, which shows non-viable distal LAD with viable proximal LAD and other vessel territory. Best strategies would be. Over to Dr. Anil.
My slides, please. Good afternoon, everybody, and I thank Dr. Kamal Sharma for inviting me into this debate and being able to talk to him or talk him into advising patients better things than angioplasty. Thank you very much, Kamal. I was planning not to come for the debate. I was at Rajkot yesterday and I wanted to dodge the debate because I don't think there's a debate. He thinks there's debate and he finds such things from ChatGPT. ChatGPT is not a doctor, so they wouldn't understand. So I want you to understand a little bit about the basics of anatomy and physiology of the heart, because this entire debate is about anatomy and physiology and about nothing else. So let's learn a little bit about anatomy. In our world, that is the world of cardiac surgery and cardiology, And in normal human world also, shape and size matters a lot. If the heart has the right size and the right shape, it's going to work all right. And if you can see on the board, on the slide, I mentioned what is the LV end diastolic volume index and what is the LV end systolic index that a patient is supposed to have. Any changes in this size and shape affects the patient. How does it happen? If there is an acute myocardial infarction, there is ventricular dysfunction, remodeling, there is wall stretch, and the heart changes its shape from an elliptical shape to a spherical shape, a more different shape. And if you look at this particular slide, you will see, is there a pointer in this? Can I have a pointer, please? So if you see on the left side, there is a conical shaped heart. So normally the heart is supposed to be conical. If the heart is that shape, the force of contraction takes care of ejecting the blood out of the aortic valve. But however, if there is a myocardial infarction, the force of contraction centers, the one that you can see on the right side, centers in the apex of the left ventricle. And if the heart keeps contracting like that, the heart dilates and ultimately the heart fails. So shape becomes of vital importance. Again, let's touch a little bit on physiology. I'm sure everybody remembers the Laplace law, and that's basic physiology and basic to cardiology also. Normal myocardial force generating capacity decreases as chamber radius increases. So if the heart dilates, the force of contraction keeps coming down, and hence it's very important to see that the heart works properly. Otherwise, the patient will get heart failure, as we know, CCF. Everybody remembers Frank-Starling law. I'm sure there is no one here who's forgotten the Frank-Starling law. Frank-Starling law says that the heart will eject as much blood as comes into it up till a limit. Once the heart crosses Frank-Starling limit, the heart starts to fail. So our patient has got a distorted heart. He's got an apical aneurysm. So what are you going to do? We need a heart that has the right shape, right volume, which will help in recovery and survival of the patient. So in this patient, what is the best? It's best to do a surgical ventricular restoration using a mannequin and revascularization using good arterial grafts. I'm sure if I give you a choice, which girl would you want to select? The one in the red or that one? Give me a hands up. Which one do you want? The left one, the right one? This one, the red one? Hands up for red one. I see not one hand. So nobody likes a bad shape. Everybody wants a good shape. So you need to get a good shape. So if the heart, preoperative heart is dilated, if you make it too small, dangerous. You make it square, dangerous. Only if you make it the right size and shape, good. Why is small dangerous? Because the patient goes into diastolic heart failure. Why is big bad? Because you don't do a good operation, the patient won't benefit. So imagine if you do a surgical ventricular restoration that does not get the heart back to the right size and shape, the heart is going to keep failing. Better not do the operation if you can't do a good operation. So the operation has to be good to be successful, not a bad operation to be successful. Look at this. I've given various variabilities. The one on the left side, I'm sorry the pointer isn't working, the one on the left up is what we are talking about. That's what this case is about. There is a apical aneurysm, the basal segments are excellent, good and viable, so those are the patients that are best for ventricular restoration. If you see the one below that, that guy is going to die if you operate upon him. If you see this one, he is not going to benefit. And maybe the top one will benefit. The top two will benefit, the bottom two don't benefit. So if you've got a patient with good basal muscle, then well, get his shape back to normal and you'll see a better heart. But getting the size and shape is very, very important. It's not a joke. You have to get it right. And for that, you have to use something like this. In fact, we must be the only team in the country who use a mannequin based on the patient's size and volume to decide how to do a surgical ventricular restoration. And this is how it is done. We open the heart, put the mannequin in, reshape the heart, get it back to normal, and there it is. The heart looks nice and good. But we are also careful that we select a mannequin based on the patient's BSA. 60 ml per meter square is the size of the mannequin. We calculate the height and weight, calculate the BSA, select a mannequin that is appropriate to him. This is a similar case. I did just a few days ago. A good apical aneurysm, rest of everything was okay. This was the preoperative echo of the patient. I'm sorry my echoes may not look as good as Kamal's echoes, but this is what the patient was like, and this is how we have done a good ventricular restoration. The patient recovered well, he is fine, he is out of the ICU, off the ventilator. We've seen worse cases. We put sizes into them and they do very well. But what is important is good sizing. Now I know Kamal is going to come up with this funny topic. He's going to say stitch trial, stitch trial, stitch trial. Anil, you are the largest enroller for stitch in India. And how can you not obey the data of stitch? Stitch did not prove anything, any benefit of SVR. This is what he's going to say. And I'm going to defend it even before he starts talking about it. Well, look at this slide. This slide shows that LV end systolic volume index and 30-day operative mortality. The more the size, the more is the mortality. That means size makes a big difference in operative outcome of the patient is data from stitch. This is 5-year mortality data of stitch according to end systolic volume index. And you can see as time goes up, as the size goes up, the patients keep dying. So CABG, so stitch somehow had concluded that CABG alone is better than only medicine. They also concluded that SVR did not offer additional benefit to patients who had LV dysfunction and underwent CABG. The stitch trial did not promote SVR, though it was the largest trial in the world for SVR. So what am I talking? Why should I be here? I should go out. I say, no, Stitch is right. Kamal is right. Let me go out. No, there were problems with Stitch trial, and I want you to look at this slide carefully. I hope everybody can look at data carefully. The blue one is SVR. The red one is simple CABG without SVR. Now, if you see, look at that 60 ml marker, and look on the left side of the 60 ml marker. The patients whose LV end systolic volume index after surgery was less than 60 ml survived better. The ones that had more than 60 ml did not do well. In fact, there was high mortality. So the important thing was the size and shape of the heart after surgery. That matters. The size and shape of the heart. Mind you, LV end systolic volume index is everything. So what was stitch trial the death knell for surgeon? No. I'm going to take a few minutes extra. Please don't say no. Everybody's been talking longer. Don't ring the bell for me. Okay, I can't let you out on this one. So was stitch trial the death knell? Stitch said, okay, don't do SVR. Do you think that was right? No, that was totally wrong. There were a lot of flaws in SVR. A lot of surgeons worked very hard in the world trying to restore ventricles. Imagine having a dyskinetic huge aneurysm and you do a 2 double vessel plasty and then you say this patient is okay. How is that okay? That's not okay. It has to be done properly to see that the patient gets okay. So stitch did not achieve the 30% reduction in LV end systolic volume index. There should have been a reduction in LV end systolic. I told you in a heart that is too big, again is same. Don't do SVR if you don't get the volume. The post-operative volumes patients did not have a post-operative volume of less than 60 ml per meter square. Mandatory CMR, that is cardiac magnet, means MRI was not done to assess volume. Many things were not done, and I will come to that entire list. Number one, all patients needed to have akinesia, yet only 50% displayed this finding. Akinesia developed from regional scar, necrosis of 35% of muscle, yet the report failed to document these scars. Cardiac means the MRI was supposed to be done for all patients. MRI was a must, and MRI done volume was required for all patients. Yet only 19% patients in stitch trial, they measured the volume accurately. And post-operatively and pre-operatively, there was inadequate measurement of volume. So imagine you're going to do an SVR and you've not measured the volume. How does it work? That doesn't work. It did not happen. Only 38% had some sort of a volume measurement, either by MRI or by echo. Only 38% in a trial of the size of stitch. And then they come up with this fantastic resolution that don't do SVR. Can you believe it? It is not possible. SVR was indicated in LV systolic, that was volume index beyond 60, yet there was no volume measurement. So imagine you're going to do an SVR, it was indicated in LV end systolic volume over 60 ml, yet you don't have a volume and you've done an SVR. So there were so many fallacies which keep that going. Keep that going. So there were many fallacies, and more than that, even inexperienced surgeons were doing the stitch trial. There is this review article that shows so much in this 7,000 cases meta-analysis. It shows excellent volume reduction, systolic and diastolic both, improvement in NYHA class, improvement in capillary wedge pressure, decrease in MR, everything happened in 7,600 patients who were meta-analyzed in this study. So Like there was the Return of the Jedi. I don't know how many of you are Star Wars fans, but there was the Return of the Jedi. Instead of that, I forget who was the villain in Star Wars. After that, the Jedi came and they won. So I would like to tell you, brother, may the force be with you. There is the resurgence of surgeons in SVR. There is great data now, great data that has come up that SVR is better than non-SVR, especially if it is done well. Yang and colleagues have analyzed nearly all the reports, all the cases that were collected worldwide, and they've put them together in one paper. And they suggested that findings suggest that patients with post-infarction LV remodeling who underwent SVR in a high-volume SVR center achieved superior long-term outcome compared to those reported in Stitch trial. This is it. Read that point very carefully. They reported. Now, what have all the series reported? They have many series are there. They say that high mortality for SAVR procedure was 6.5 and 18%, and survival of 89%. Huge survival for LV dysfunction. The 9-year survival, the second last 9-year survival in those who underwent DOR procedure was 62%, where they took such sick patients. And the risk factor for any time with high SVR was there, and a lower pre-op EF was there. But the most high risk factor was an LV end systolic volume index of more than 80 ml. A huge number of trials. There is another trial that reported 82.4% survival if SVR achieves a 33% reduction and postoperatively end systolic volume index of less than 90 ml per meter square. So even at that, they said it is good. At all values, they said it is good. So SVR, where does it stand? SVR will be an important tool in the surgeon's armamentarium to treat heart failure. Period. You have to get the volume. LV end systolic volume has to come back to less than 60 ml per meter square if your patient is supposed to live. Otherwise, he's going to die. And then about CABG, I have no controversy. There is nothing about plasty. There was a lot of talk about these funny tools, orbital plasty, IVL, IVCL, a lot of funny tools. But nothing can beat surgery. Why? Simple. I want all those who have not read this paper, read this paper once. Why does that happen? See, there is a lot of atheroma. Angioplasty addresses only the lesion, not the atheroma. There will always be non-flow limiting plaques that will rupture and cause re-MI. It's not your fault. It's the disease. CABG works because we go beyond all the atheroma. And even look at syntax. Even in simple syntax scores, you see how the graph goes up, even in simple syntax, which is our patient, 0 to 22. Over time, the graph goes upward and downward. CABG goes downwards, angioplasty goes upwards. So any day, and look at these studies and trials, everything, myocardial infarction favors CABG, repeat revascularization favors CABG, repeat MACE events favors CABG, repeat strokes are equivocal. So look at any data you get in the world. Look at this list of trials. What is better, CABG or PCI? If you want your patient to live, even in type A lesions, my friends, you have to choose wisely. We have BIMA, and we have lived with BIMA, and we will live with BIMA. I really request that if you get a patient like this who has got an anterior aneurysm, double vessel disease, let's put some arterial grafts and let's do a good SVR to get LV end systolic to less than 60 ml. We want the person to live. Choose wisely, my friends. Choose wisely. There is no debate in this. I don't mind if Kamal wants to talk for the next 15 minutes. Thank you very much.
So, Dr. Anil, you try to make your point. Dr. Kamal Sharma now. PTCA the best strategy. Over to you, sir.
थैंक यू अनिल भाई आई थिंक आपको 21 तोपों की सलामी मिलनी चाहिए 21 तोपों की सलामी so I'm going to give you 21 gun salute I'm going to give 21 points why angioplasty should be done so every time I used to give 10 point salami but Anil bhai spoke very well he's a beautiful and fantastic surgeon whole idea of putting this thing in debate was that whom to do when to do and with whom to get it done that is very important so if we can make that, that is, so this was the clinical case scenario. So he talked about 82% survive 4 years. That is one thing that I'm going to tell you what happens to my patients if I do angioplasty with this kind of a scenario, how many survive. Let's look at his patient's GRACE score. He's going to survive, what is his chances of mortality for this clinical scenario? 8% at 6 months. Not very high. Now, this is an angiography, and I want cardiologists sitting in the panel to tell me, do you want to send this kind of a lesion to a surgeon for a bypass surgery? This is a lesion, simple chicken lesion. Half of the times your fellow will do it, so you are sitting in the cath lab, and it'll be done. This patient has got a small aneurysm down there, and you have got 2 lesions. no lesion aneurysm size is mentioned, and for that small aneurysm you want his heart to be not only opened, one side you're saying minimal thoracic, don't open his chest, we'll go minimal, and on the other hand you're arguing we'll open his heart also, put a balloon inside also, but we won't let you put a balloon inside the coronary artery without opening the heart. Then beyond that, I also want you to take to what he was talking about, what is going to be breaking the news headline. This is common story. Dog biting somebody, nobody's talking about it. But when you bite a dog, it becomes a headline. So that's what the Stitch 2 trial was. So surgeons thought we'll do a study and we'll show cardiologists that you guys are knowing nothing. We'll open the heart, we'll repair the aneurysm and we'll do better. So they hired a dog called Stitch 2 trial and tried to bite it. Now reason number one, first pehli top ki salami, you ask AI tool, put this question in an AI tool, Copilot, whichever, Chat GPT, what it will say as the first option? It says angioplasty. You go to Perplexity AI, it will say angioplasty. So this is again Perplexity AI tool. I already showed you Chat GPT. I've put that thing. So AI. So now he's saying Chat, these are not doctors. They won't know it. Okay, sir. Let's go to the guidelines. What about a proximal LAD stent in a 2-vessel disease? Where do we stand as an angioplasty? Again, angioplasty and bypass, both are class 1. That's fair. He talked about Syntex trial, where our MiG-27, which have already been outdated, were compared with your F-16s. 1 year data for this kind of a lesion shows strokes are higher in bypass surgery as compared to angioplasty. Otherwise, for this kind of a Syntex score, at 3 years and even at 10 years, all-cause mortality is comparable. At 10 years, all-cause mortality. Sir very beautifully showed some slides and skipped that at 100% mortality at 8 years in the trials he was showing, if you can visit his slides. In my case, at 10 years, our survival all-cause mortality is better or equivalent to bypass even in the best of the hands. So based on Syntex score, let us look, what is our chances that this patient undergoes, I've put his angiography, Cardiocon 2024 is the name of the patient, and if you put that in, 4-year mortality is 15% for angioplasty. For bypass, it is 9.9%, but it is again if you don't do an aneurysm. So at 22 Syntex score, it's similar. And we talked about this slide. He very well showed this, that where it overlaps. Now look at the other slide which he hid, the side of time since operation and survival. If your volumes post-operatively were less than 60 ml per meter square, then only you survived 9.8% times of event rates or mortality happened. But if you don't, 27% died. So you need also to choose a surgeon who can actually repair the aneurysm. So what is the problem with SVR? My point is SVR mortality. World over, if you look, 1-year mortality is almost 45%. Now it is okay to anticoagulate your patient and give anti-failure with the 4 pillars and 8 pillars of heart failure and fix his coronaries for the viability rather than have 25 to 45% chance of dying on table. What about 2-year? It goes on, no specific data. 5-year, 60 to 83%. And 10-year survival, only 48%. Very poor outcomes. So that's why my top number 5 is we have drugs to manage the aneurysm when my angioplasty risk is pretty low. Look at Revived. He should have talked about another trial called Revived. This is post-heart failure where 4 pillars of heart failure were used. And after that, what was the outcome? That LV dysfunction, even less than 35% viable myocardium, PCI when added to OMT did not reduce. You do anything with 4 pillars, you're talking about even doing a bypass surgery in these patients. Bypass don't do any additional benefit in such cases. Which LV aneurysm should not be operated? You Google this and you'll get size of the aneurysm, volume operator, which how many surgeries SVR a surgeon is doing, what is the operative method used, how much viable myocardium is present, what is patient's functional class, what is his comorbidity. These are the determinants that will tell you. And I will take each one of them one by one. If the LV end systolic volume is less than 60, you do not need it. If your LV systolic volume is more than 80, you don't do any benefit. It's the very sweet spot between 60 to 80 that you choose these patients for an SVR. Okay, sir, chalo choose kar liya. But tell me a center that can do that many number of SVRs. So let's look at the volume, how it is defined. On top of that, you need a good echocardiographer. He showed some echo, which he said Kamal would do better. I'm sure I would. But sphericity index and LV and systolic volume indices are something that you need to measure. How spherical the aneurysm is, how much your LV indices are, what is your conicity index. All those parameters need to be defined either by an echo or by an MR before you actually choose between too fat a lady and too thin and beautifully shaped lady, which Dr. Anil Bhai was proposing. But that is a sexist comment, sir. On the contrary, if that beautiful lady is going to be somebody who's going to eat your brain every day and night, would you be interested in getting married? I want to see the hands raised. I would rather do a bariatric surgery and then obese lady and have a peaceful married life for rest of my life. So inadequate operative volume. What is the operative volume that is required to be defined? That is something like 20 to 25 surgeries an year. That's the number that you need. How many patients, barring Anil Bhai, I believe nobody does that number of SVR in a year in this part of the world. If suboptimal outcomes are there, poor volume reductions are there, if the post-operative volume is left more than 60, the outcomes are going to be equally bad. Inappropriate patient selection, if the ejection fraction is very low, if the comorbidities are more, if the intraoperative management issues are inadequate, if their failure to address the associated COPD, etc., patient is not going to benefit. What about viability? If there is non-viable aneurysm, you will not get benefit out of SVR. We all know this, it has to be viable. And that's why the imaging mentioned that this patient in the viability assessment had non-viable aneurysm. Non-viable aneurysms, if taken off, will not help much. Severe heart failure, class 3 and 4, significantly reduced, may not benefit from EF of less than 30%. Class 3-4 patients will not benefit. Comorbid condition, high surgical risk, again, should not be undergoing an SVR. So in summary, large size of aneurysm, non-viable myocardium, low surgical volume experience, inadequate surgical methods, severe heart failure symptoms, significant comorbidities are not a candidate. So what will you do for this patient for ischemia? You need to do something. You'll fix the coronaries. The other reason is now we have newer devices. This device called Revivent implant can actually be used to anchor, and it's an approved therapy for closing. This is the parachute LV restoration device. You can put this kind of an umbrella device in the aneurysm and close it off. This can be done percutaneously. So, sir, if your first generation MIGs, if my Syntex are out, now I have got Predator drones. I don't even need a pilot. I can put that SVR closure by a non-pilot driven drones, which can actually bombard that aneurysm and close it forever. The struts have actually become too thin, the polymers have disappeared, and is Lima really the best bet, which was the biggest argument that was coming out? It's not. In PREVENT-4 trial database, it was shown that the Lima revascularization had 12 to 18-month angiographic failure rate of 8.6%. This is, ek baar Lima lag gayi, sari jindagi ka bima ho gaya. Not always, depends on who the surgeon is. I can assure and vouch for Dr. Anil Jain that every time he does a CABG and the patient comes with MI, his grafts are flowing. I get a new vessel which has got. I can agree to that. But can you vouch for that for every patient, every surgeon, in everywhere you get it operated? Probably no. This is what data says. 8.6% will have their Lima occluded. That's the high rate. What about, they say contrast nephropathy, but even AKIs are higher. Look at the AKI rates in patients undergoing CABG. Even that's worse. He showed this slide. Aapke paas kya hai? Mere paas Ma hai. We also have Ma, and which is Ma Yojana ka Ma. And that's where the angioplasty is free. Now what has happened is also we have to consider government ka Ma. Because now the package of a surgeon getting more money in bypass compared to angioplasty. So let's save that money also for the government, do an angioplasty so that 2 patients can get angioplasty in the same amount of money that a surgeon gets for 1 surgery. अब उसमें वो आपने SVR किया तो एक एक्स्ट्रा कोड भी लगाते हैं तो वो और महंगा हो जाता है उसमें 3 का bypass की जगह we can do 3 patients angioplasty. So we also have Ma, and very other simple reason is very short duration of stay. Ask your patient, 5 दिन हॉस्पिटल में रहना पड़ेगा, छाती चीर के ऑपरेशन होगा, सीसी सुंगाएंगे, मुंह में एक ट्यूब डालेंगे, वेंटिलेटर पे 2 दिन रखेंगे, 1 महीने के बाद आप ऑफिस पे जा पाओगे और सारा दौड़धाम कर पाओगे, या मैं हाथ से एक सुई डालूंगा, एंजियोप्लास्टी करूंगा, बातें करते करते अगले दिन छुट्टी दे देंगे और आप 1 वीक के बाद मुझे पता जाना. What would the patient choose? The pain, the scar and the non-invasiveness, if there is no scientific benefit, which I showed. Of course the anesthesia, and very important, the regroup trial. 3 years, no difference in all-cause death, mortality, revascularization, whether you do bypass or your so-called minimal invasive, which our expert is going to probably come and talk about. Very important, now we have imaging. We can look what exact size, what size of angioplasty, and very important, when a patient goes for a surgery, it's not the patient, the family goes for a surgery. It's like a marriage, it's like a conference. If I have to organize a conference, whole family has to come, whole team has come, whole department has to come, whole Sal hospital has to come, marketing team has to come. Same is like for a surgery. You do a bypass surgery, aje operation che. Son has to take leave, mother has to take leave, stay with the patient for 7 days. It's not one patient getting operated. Angioplasty, સાહેબ મારા સન જોડે હૈદરાબાદમાં છે વાત કરી લો હા ભાઈ એક્સટેન્ડ મૂકવાનો છે ઓકે ગો હેડ એન્ડ ડુ ઇટ ધેટ્સ હાઉ ધેન angioplasty is often finished. So that's the 21 તોપો की salami that I wanted to give. This is the patient, small aneurysm, underwent a PCI, went home, doing well, simple lesions. I am sure anybody in the audience would have done it the same way in the intervention council. So this is the hunting of the mountain for a small mole. So cardiologists and cardiothoracic surgeons were fighting, and then they realized the cardiothoracic surgeon came, they had capped the cardiologist. So they designed a trial called stitch trial, and they told him to bring the stitch trial. The stitch trial came to the surgeon. Surgeon was very happy. Now I'm going to bombard and the cardiologist is going to be finished because he is not going to be able to fix the aneurysm which I can. But they did not realize that the stitch had actually stuck to them, not to the cardiologist. It showed no benefit, and they then thought of sitting on it. They sat on it. Unfortunately, it blasted them all. Thank you very much. That's why I rest my case.
Sir, want to answer?
I will talk to you. I'll talk. Yeah, hi, good afternoon. My name is Dr. Atul Maslekar. For those who don't know me, I'm into cardiac surgery for last 38 years, and I'm presently with NH. Now, a good debate, and I thought I'll see more public here because it's a very interesting topic, and this is the type of patient that we see today with very poor LV. But what Anil said is right, because I'm not denying that what you said is wrong. What Anil said is right and justified based on what type of patients we see. What Kamal was talking also is right. But what Kamal is saying that in a patient with severe LV dysfunctions, totally dyskinetic or akinesia, just do an angioplasty. My question is, why do anything when it is a dyskinetic
If it's
segment
viable.
and it's not going to improve? See, this is just each patient. Today what we face is a controversial patient where every patient has to be individualized. It's not Tom and Jerry that we are talking about. When it comes to, and again, I took it a little strongly when Kamal commented that the surgeons, patients go home and had to stay in the hospital for 7 or 8 days. We have also seen enough complications, so let's not go into that. I thought cardiology and cardiac surgery was always two arms of one body. And if you're going to, stab each other in the back, I don't think any such debates are going to get us any solutions. So now coming back to the scientific basis of the topic today, I think both of them are justified. The today's patient, what he has said, a small apical aneurysm. I think I will also go with Kamal in angioplasty. But when it comes to evaluating such patients, I can assure you, most of the time the echocardiography is never done by the cardiologist. It is left to the echocardiographer, who may be a technician or a trained non-invasive cardiologist. It is not just the ejection fraction. I think, as rightly said, it is the end systolic volume index, which is very important, of more than 40 ml. 60 ml definitely, 60 and 80 is a gray. But if you have a LV which is hugely aneurysmal, dyskinetic, and patient has multi-vessels, I am going to go ahead and do surgery on him rather than subject to him to some other. Sometimes we don't even do LAD because LAD gets implicated in this dyskinetic segment, and when we are doing the aneurysm or the DOR procedure, that whole LAD territory is gone away. But there is definitely benefits from grafting and definitely benefit from reducing the LV size. So coming back to the point is, doing identifying every patient individually, understanding how this patient is going to be in the future, whether you want, there is a mortality. There is a mortality in a routine CABG also. No surgeon can say that a 60% ejection fraction patient is not going to die. We do our best. Similarly is the case with angioplasty. So when it comes to the patient specificity, I think we all, as cardiologists, as physicians, have to get together. Our findings have to match. Our plan of action has to be together rather than deciding that just because I'm a cardiologist, I'm going to do angioplasty, or I'm a surgeon, I'm going to do surgery on him. I think identifying these patients, doing proper investigation. Viability study, as also is mentioned, is a bit questionable because we don't do MRIs. And the question is, getting viability study or MRIs, also who is the person who is doing it for you. You know, there are very few cardiac MRI doctors who will give us the proper, exact what we want. So eventually it boils down to identifying, finding out the proper, and then sitting together as cardiologists and cardiac surgeons, I believe, that's my opinion, and I'm working at NH with 4 cardiologists where I do work with, we discuss every case which is questionable, and then coming to a final fine answer is what is the treatment. This case, I'll go with you, Kamal, but what Anil also has justified is right.
Absolutely, the whole idea was to create awareness, and it's always in light note. The point is that we need to identify one sweet spot where the patient should get it done at a high volume operator with a size of between 60 to 80. If the volume is more than 80, the benefits don't appear. If your aneurysm is more than 120, probably it's all scar. And if you scar, you try to make contract, it will not contract. That is the whole idea. So if you have a viable scar and you do it, you have a viable aneurysm on the proximal part, then it makes a sense. Again, if it's too small, don't do it. Too large, again, doesn't. There is a sweet spot between 60 to 80 ml per meter square. That's where, and that's why it becomes important to find out LVSCI.
I have a slight difference of opinion about volumes. Every cardiac surgeon who's going to do an SVR should go to the echo room himself and have a look. You can have a large apical aneurysm, very good basal segment. In fact, those are the ones who do the best. I've had patients with 200 ml volume, 250 ml total volume, and very good basal segments. Everything is good. Only a single LED huge aneurysm. One of that I showed here. So they are the ones that do the best. So it's not only the size you have to go with, purely size, but how much muscle is left? What will I do? Is it isolated like a pseudoaneurysm? It's gone up big. All those things you need to see properly, and only after a good judgment, if it's good. Otherwise, I think I agree with him. Let the patient go home. He's better off. And medicines, your 5-6 pillars. That's the way. So good judgment, good analysis. I go and see every single SVR echo myself, and only then I do an SVR.
The point was to bring out, all in light humor, but point was to bring out that SVR patients are being actually either left on medical management or don't get an SVR done. I think there are a lot of patients who are eligible candidate for SVR, and to identify a sweet spot. So because what happens, cardiologist, once he sees aneurysm, either he'll do an angioplasty or do a simple bypass or leave on medical management. There are subgroup of patients, you do a viability study, find out if the SVR is in the sweet spot, he is a good eligible candidate, he can go for SVR in a good operative setup. That was the take home that I wanted.
I think, sorry. In this kind of patients, I think we have to remember 3 V's. One is a ventricle, second is a valve, and third is a vessel. What is the quality of vessel? Is there associated MRTR with it? And how viable is the ventricle? Then only you're going to get an answer out of it.
So we have an expert, Dr. Chirag Doshi had to go.
We have got Dr. Chirag Doshi.
So he's sent a videos on a
he will guide us.
minimal invasive SVR. It's on, it's on stage.
I thank you for this invitation to provide my view on the management of this 70-year-old man with coronary artery disease with severe aneurysm who needs surgical revascularization, but also has an apical aneurysm. Both Anil Bhai and Dr. Kamal Bhai have discussed valid points regarding optimal management. So I am here to give my 2 cents regarding the possibility of approaching his surgery via minimal invasive approach. Now we'll be seeing two different procedures here, and I will explain in a minute. We can easily achieve total arterial and complete revascularization using Lima and Rima or Lima radial Y grafts. Here we are using a radial graft using stay sutures. It is possible to create adequate exposure and stability to create Y graft using 8,0 polypropylene. Then using 7,0 proline, first we will create Lima to LAD anastomosis and later do the radial OM major anastomosis in a similar fashion. So with proper manipulation and exposure, it is possible to reach all coronary targets via a left mini thoracotomy incision. What I want to show is that a small LV apical aneurysm can also be easily tackled via the same incision as LV apex is in the right front of you. Recently, we operated this gentleman with a chronic LV pseudoaneurysm of total 10 centimeters size and severe LV dysfunction via mini thoracotomy incision. The cavity had a large eccentric levered thrombus, but fortunately no active chamber rupture or contrast link. So I entered through the fifth intercostal space and gently dissected over the pericardium. Rest of the dissection was done after going on peripheral bypass. Antegrade cardioplegia and clamping aorta using a Chitwood clamp. Now we incise the LV cavity to vent it. As you can see, there is a lot of chronic thrombotic material in the wall of pseudoaneurysm, which I am now removing with my finger. We clearly see the neck of the LV aneurysm. It is easily 3 to 4 centimeter. The trabeculations we see is the part of the true LV cavity. I cut the piece of Dacron graft covered with inner surface with fixed pericardium, as it will be the portion in contact with LV cavity and blood. Using 4,0 polypropylene, I am suturing the patch all around the healthy margins of the LV pseudoaneurysm, which lays open. After ensuring hemostasis, we clamp off and heart regains its activity. We come off bypass uneventfully. So we can tackle this huge aneurysm through minimal access approach. I'm sure we can handle aneurysmography or aneurysms repairs on an arrested heart or sometimes even a beating heart if it's small in size. Thank you so much for your kind listening.
Thank you, Anil Bhai, and all the panelists and chairperson. We